allow me to quickly give a quick introduction on what CREED is about. So as I've said, CREED in full is the Coalition for Health Research and Development. And CREED it brings together a number of civil society organizations. So this is a coalition that was founded in 2015, and it brings together, I would say, local and international civil society organizations that are working together to advocate for an enabling policy environment to facilitate research, innovation, and access to high impact products and technologies in Kenya. I must say that CREED has been instrumental in amalgamating all the efforts of these agencies, including research institutions, including government organizations, the non-state actors, to create awareness on the importance of increased investments and creation of worthwhile regulations that support research, development, and innovation towards achieving the universal health coverage in Kenya. So the reason why we are here today, we have put up a strong panel of experts, as you can already see from the platform. And we are going to look at the contribution of research, development, and innovation to universal health coverage. So within that kind of discussion, we are going to delve into pandemic resilience. We're going to look at the connection between research and development in pandemic resilience, but again, how that contributes to the universal health coverage. At the same time, we are going to look at the component of research and development within the poverty-related and neglected diseases, and of course, still connecting that to UHC. We will also have an opportunity to look at the fiscal space of Kenya's investment within research and development. There is adequate data that we will be happy to share within this platform. So be ready to interact with heavy data on the government investment on research and development. That will be enriched by one of our representatives from the Ministry of Health, who will have a chance to share with us some of the priorities of the Ministry of Health, some of the plans that they have. And then we'll also get an opportunity just to engage and see what are some of the points of convergence of the work that we are doing as the non-state actors and the Ministry of Health. Again, we will also be privileged to get to hear from the South African context, just to get to know what are some of the milestones, what are some of the unique experiences that they have from the South African context that we can also learn from and see then how we can push forth the advocacy agenda for research, development, and innovation in Kenya. So with that said, allow me to quickly go into a quick introduction of the panel. So the panel, we have John Paul, as I've already mentioned, we have a strong team of experts within the health sector in Kenya, of course, with a strong backing from the civil society as well. So the discussions that are going to come in here, be rest assured that these are discussions that are going to come out from experience, but also backed by sufficient data. So we have John Paul. John Paul is a public health professional who has a vast experience in health systems, strengthening and health advocacy. So John Paul has extensive expertise within health policy formulation, monitoring, evaluation, health system strengthening, and program management. So currently, he is the Health Research and Development Officer at PATH. The second panelist that I would have the privilege of introducing is Imalin Gusale. And allow me to admit that the bios that we have for our panelists are too long to read and to exhaust within this section. So I would just mention the highlights. But again, during the networking session, you'll have an opportunity just to get to know much more about our panelists. So Imalin Gusale is a revolutionary thinker and an outstanding communication and advocacy professional that has amassed extensive years of experience within budget advocacy, health research and development, international relations, and government. So Imali currently works with DSW as the International Advocacy Officer, supporting policy advocacy in Kenya, Uganda, Tanzania, and Ethiopia. I'll then quickly move to our third panelist. Our third panelist is Dr. Jose Arono. Dr. Arono is a co-founder and managing partner at the E&K Consulting Firm, which is a Pan-African advisory and investment firm that has provided lots of solutions to healthcare, finance, technology sectors. Through the E&K Consulting Firm, I must say that Dr. Arono has advised, has made significant contributions within the healthcare system, and he has advised on healthcare transactions worth millions of dollars within the global pharmaceutical industry. He has also contributed to development of strategies for health businesses worth over millions of US dollars, but also led several health programs on behalf of hundreds of clients in over 20 countries in Africa. That's Dr. Arono, and you'll have an opportunity just to get to listen to him on the pieces that he will have a chance of presenting. We are also joined by Dr. Joyce Wamiswe. Dr. Joyce is the current head of Division of Research and Innovation under the Directorate of Health Policy, Research, Monitoring, and Evaluation at the Ministry of Health, Kenya. So Dr. Joyce is a medical doctor with a postgraduate training in applied epidemiology. So she's a field epidemiology and a laboratory training program alumni, and her interests revolve around advocating for the use of data and evidence in informing decision-making, as part of her contribution to strengthening healthcare systems. I will move ahead and introduce our next panelist. We have Dr. Catherine Kyobutungi. So Catherine holds a PhD in epidemiology from the University of Edinburgh, and she has a master's in community health and health management. So Dr. Catherine currently is the executive director at the African Population and Health Research Center, that is APHRC. And she was formerly the director of research and also served at the same institution in several leadership roles over the past decade, having joined the institution as a postdoctoral fellow in May 2006. So that is the panel that we have, but we also privileged to have Doreen Pretorius. Doreen is joining us from South Africa, and we will also have an opportunity to get to hear from Doreen in terms of the milestones that they have made within the context of South Africa as regards research development to the attainment of universal health coverage. All right, with that said, and with the good understanding that we have with the team, allow me at this point in time to bring in our first panelist, John Paul, who will have an opportunity to talk to us about the components of pandemic resilience, and just looking at that within the lenses of research and development, and also the components of innovation, how that in turn affects the attainment of the universal health coverage that we are looking at as the overarching theme of this conference. So JP, I want to give you this opportunity to take us through what you have for us within the context of pandemic resilience. And then from then we'll see what lessons we can draw from it as we seek to enhance R&D for the attainment of universal health coverage. JP, over to you. Welcome. John Paul? John Paul, sorry, we can't hear you.
Can you hear me?
Well, it seems John Paul is having a connectivity issue. Tim, can you hear me?
Yes, can hear
Yes,
you.
I can confirm I can hear you.
All right. John Paul, I see you're back. Would you want to take it up? John Paul, sorry, we can see you speak. Unfortunately, we cannot hear sound. All right. It seems John Paul is having a little bit of an issue with the connection. John Paul, feel free to just work on that. Then you'll have an opportunity of coming in. Well, I would want to use this opportunity to bring in Imali. Imali, I know you're coming in with a lot of experience when it comes to budget advocacy and also, just looking at the advocacy issues around research and development. I would want you to come in. I see John Paul is back. John Paul, can you?
Not sure whether you can hear me now.
Yes. Yeah, you're on. Take it up then.
My apologies for the technical hitch. And thank you so much, Eric, for granting us this opportunity to add into this very important piece of work that would add into strengthening universal health coverage, and also to thank my fellow panelists for joining this conversation, and of course, importantly, to the organizers of a hike for providing this platform for us to deliberate on this. I just wanted to start by quoting the speech that one of our forefathers, the president of Ghana, gave during the 1963 summit on the African Union, African Unity in Addis Ababa. And I quote, he said, "We shall accumulate machinery and establish steel, iron foundries and factories. We shall link the various states of our continent with communication. We shall astound the world with our hydroelectric power. We shall drain marshes and swamps, clear infested areas, feed the undernourished, and rid our people of parasites and diseases. It is within the possibility of science and technology to make even the Sahara bloom into a vast field with verdant vegetation for agricultural and industrial development." 58 years later, this vision is still alive, and we are still asking ourselves certain questions as a continent. Where is the place of research and development in strengthening health systems, in achievement of universal health coverage? And in unpacking this, I wanted to trickle it down in the context of health systems resilience, because until we are able to, we cannot talk about what we don't know. We can only approach what we don't know by what we know. So if we look at health system resilience, which scholars have also defined as the capacity of health actors, institutions, and populations to prepare for and effectively respond to crises, especially in maintaining the provisions of essential health services when crisis hits. It is important that we understand that for the health system to effectively respond to crisis, it requires medical tools that functionally fit to the context and able to provide the accurate information for decision making. And of course, these tools may include, diagnostics for early detection, tools for surveillance, therapeutics for treatment and control of diseases, among others. And of course, we understand that such tools are a product of health research and development. Therefore, when we are talking about pandemic resilience in the context of research and development, an effective pandemic resilience will there be a factor or will be a factor of both that vigorous pandemic health response and a highly proactive and functioning healthcare delivery system, which must therefore be supported by the products gotten out of health research and development and introduction in the market at the earliest time possible. Both of these systems must work in concerted effort during a crisis. And indeed, this can only be so if it is designed as such, long before a crisis strikes. So if that is the essence, or if that is what we would define as a pandemic resilience in the context of health R&D, how then, or which are the strategies that we can put in place as a continent, as a country, to ensure that we prepare effectively way before epidemic strike or pandemic strike a country or our globe, if it is a pandemic? And I put this in 4 big buckets, which I will try to ventilate on briefly for each one of them, just because of time. So the first one, first key strategy is the need for a sustainable mechanism for investment and financing in research and innovation for health. We know that Africa only puts about 0.2% of its GDP in research and development. That's total research and development, against a global average of 1.7%. And by the way, that is the lowest in the globe. And most of our funding in Africa comes from, externally provided or external donor funding. And we know what that means for us. Subsequently, when you go down, you realize that this funding is either uncoordinated, they are inadequate, they are unsustainable, and often it never targets the national or the regional research priorities. As such, we must ensure that Africa develops and implements a sustainable mechanism for investment and financing in research and innovation for health. Then how then can we ensure that Africa puts in these mechanisms? One is to develop a very strong investment case for health research and development. Our policymakers don't see R&D as an economic arm of a country. Yet we know that in developing countries, for every dollar put in R&D, they reap back $16. And if you extrapolate that further, it goes to about $43 more. So we must continuously, in the African context, in the Kenyan context, continuously provide investment cases for R&D. And there is no better time to do that than this time when we are still battling and fighting COVID-19. We need to encourage investment in health R&D ahead of these pandemics. We must ensure that we strengthen R&D within the routine health system strengthening. So when we have resources for system strengthening, we must make sure that we incorporate or integrate R&D within that. And of course, we need to create, a new mechanism for funding, especially I would call domestic funding, even if it means through concessional loans that come from the African-wide banks, the African development banks, and so on and so forth. And these must support our national priorities. And of course, need to strengthen R&D as a part of the pandemic. We should never waste. Some people say we should never waste a crisis. It is important that at this time when we are fighting a crisis, we then need to strengthen the R&D response and the R&D aspects when we are fighting a pandemic. The second biggest bucket that and strategy that I would put in for consideration is the need to generate new knowledge and align that to the goals and targets of the country. And subsequently on that, advocate for the translation of that knowledge into products, services, policy, practice that would improve our healthcare system. And we know, and we need to appreciate that, yes, Africa has made huge strides around strengthening health R&D ecosystem. around the continent, and especially countries like Kenya that has put in a lot of effort in strengthening the R&D ecosystem. However, we still have a journey to make. This journey needs us to have a culture of utilizing research outputs to inform policy, practice, and implementation. Most of our research institutions, including our academic and research institutions, majorly do their research for publishing purposes, but not necessarily to translate it into policy and practice, or to create a culture of relying more on research and data for decision making. We need to foster, linkages between academia, government institution, the industry, so that that translation can happen from the lab to to the market. And again, create that link to that point, creating a very strong public-private partnership, so that that linkage between academia, government institution, and industry can effectively translate research and innovation output into commercial and viable products into the market. And the need to have that entrepreneurial mind when we are working with the trade, with academic institution and government, and of course tie that closely with development of coherent policies and legislation that would spur that entrepreneurial aspect of research into products into the market. The third big bucket that I wanted to raise is, the need to strengthen capacity for sustained and integrated, coordinated, collaborative research, innovation, and translation of that into the health sector. And one of the big things that we need to do under, in ensuring that we are able to create a sustainable and integrated and coordinated and a collaborative approach is working towards the same goal. I have to mention here that Africa is not short of, continental strategies that try to steer us, or that tries to enable us work towards the same goal. We have the Science, Technology, and Innovation Strategy for Africa 2024 that reminds us of the need to utilize and build on our research capacities to produce new and effective medicines, diagnostic, vector control tools, and vaccines, and to promote research, invention and innovation in traditional medicines, and strengthen local health ecosystem, taking into account the socio-cultural and environmental situation of the people. We also have, the Health Research and Innovation Strategy for Africa 2018-2030, and this document clearly reminds us that the long-term and sustainable resolution of Africa health challenges rests in African designed and African-led research, as well as active participation of Africa researchers and innovators in local and international health, including, health system and medical health technologies innovation ecosystem, among other, key continental strategies that really help us work as one continent, as one region, including, the African Health Strategy, the African, that is the key blueprint, which is the African Union Agenda 2063. The other big item under that is, we need to continuously support our supranatural national research organization. We have the African CDC. I think during this pandemic, Africa CDC has really gotten a lot of limelight because they have played a very significant role, both in infection prevention and control, and right now in vaccine development and deployment. And of course, they are still playing significant role even as we are trying to repurpose drugs and introduce new therapeutics into the market. And of course, these kind of institutions in Africa have not previously gotten enough support from member states or even from the institutions that really need to provide that support technically and financially. So we need to continuously support our supranational research organization, specifically highlighting here Africa CDC, because it cuts across the entire continent. But as when we have other research institutions at the region, like the East African Health Research Commission, how best are we supporting such institutions to provide the necessary support at country level and at multinational or multi-country level, so that we are able to respond effectively way before a pandemic hits or an epidemic hits a country or a pandemic hits the region or the continent. The other key big buck of item that I wanted to raise is the need to strengthen and harmonize regulatory, ethics, and intellectual property systems in order to maximize the benefits from the African-led research and innovation for Africa and global community. We do know that in Africa, we have a lot of regulatory bodies, and these as such creates a great barrier to the introduction of new medical products, even when we are in a crisis. Point in case is, rapid diagnostic tools for COVID-19. Currently, there are certain countries that are still yet to approve certain vaccines so that they start, vaccinating. But how then can we do this from a continental point of view? African member countries must align their regulatory systems to the African Union Model Law on Medical Products Regulatory Harmonization. And additionally, I call upon, we need to call upon member countries to ratify the African Medicines Agency as a key platform for harmonizing our regulatory system and encouraging health research, development, and innovation, especially the upstream research, and of course, the need for faster introduction of products gotten out of research, and need to strengthen, the sharing and platform and systems to optimize research delivery and embrace the principle of reliance. And of course, the last point that I wanted to raise here is that we need to create an environment that allows for ease of adoption of emerging technologies and supporting platforms to improve the health and the R&D ecosystem. Thank you.
Well said, John Paul. Thank you so much for the important assertions. Just to recap quite a number of insightful thoughts, you have given us, quite an elaborate definition of health systems resilience, just talking about the capacity of the health actors and the institutions, including the people, to prepare and effectively respond to crisis. And you've gone ahead to give us quite a number of resilience strategies that we can leverage upon. We have talked about encouraging, just looking at strengthening health R&D as part of routine health system strengthening. You've talked about the components of better use of existing funding through enhanced coordination. There is a component of expansion of existing mechanisms and organizations that that can take lead within the R&D space. Or quite a number of insightful points there. You've also made mention of creating strong public-private partnerships, just to identify, advance, and scale up commercially viable research outputs. Again, just the need to create sustained, integrated, and coordinated and collaborative research, innovation, and translation for health. So this, for me, I look at them as some of the strong strategies that our countries can adopt. And talking about that, looking at the context of Africa, where we have had, allow me to use the word misfortune of having to, deal with some of the poverty-related pandemics and conditions and diseases. I believe this is actually one of the great areas that we need to, just to pick and learn from. And with this, I would want to bring in Imali, to talk to us we are coming from the point of pandemic resilience. And as Africa, we've always been at the forefront. You know, we've always been at the direct recipients of little investment when it comes to poverty-related diseases. So how is it then? How does the space look like? And what are some of the takeaways that we can have looking at the poverty-related diseases? Of course, still taking into consideration the component of R&D as we seek to attain the universal health coverage. Over to you, Imale Gusale.
Thank you very much, Eric. First and foremost, I must thank the AHIC team for inviting me in this caucus. I do present two groups of people. The first is young women and girls, and the second is young people in general. We are the most neglected people. And I did not say this as a way of just putting it in speech, but rightfully so. Because when you look at the way the COVID vaccine has traumatized the world, we have been the most affected. We've seen a huge number of young women moving disproportionately to the poverty docket, even though they had, we had in the recent past had a lot of programmatic issues that were put in place to make sure that at least young women can afford $1 per day. And retrospective to universal health coverage, ideally the question of universal health coverage seeks to make sure that every person gets health care at bare minimum, which means that if you don't have money, ideally you should be at the very least be able to get healthcare. But with the way times have changed, and of course not just the COVID crisis, but just the disproportionate awareness of how badly poverty-related and neglected diseases have been neglected, makes it a key issue when it comes to global health research and innovation. So I'll quickly move on to basically what is happening and a retrospective to this discussion today. John Paul has talked a great deal about Africa and the 2% commitment. And Africa indeed has tried by stating the essence of research and innovation. But in as far as investments are concerned, there are so many questions that are yet to be answered. And these questions are not to be answered by only the African decision makers, but also individuals in their private capacities. Because sometimes we often forget that without the jobs that we hold, we could end up being in that bracket of poverty, and we could be regarded as another statistics. Less than 1% of global health investments come from Africa, which means more advocacy needs to be done to ensure that the expenditure on research and innovation becomes priority. And this is not just because of COVID, but also because the studies from the last discussions we've had even in AHIC have proven that if we have another emerging infectious diseases, it means that we'll be stuck. And I mean literally stuck. So it is crucial for us to look at what investments have been put in place and what can we do differently so that we can make sure that we even have a buffer, a way of investing in the sense that if there's another emerging infectious diseases, we have sufficient resources to make sure that we are not stuck. If we look across the continent, health facilities in Africa can only minister to less than 50% of the population. And I do not mean the population that has afforded to be in this call or even attendance. You are actually rich compared to the statistics because it means you can afford internet. Young people like me cannot. And I mean like me because I have the privilege of working. What if I did not have a job? What if I did not have any healthcare? It would mean that I would be part of that 50% and not able to access modern health facilities. Retrospective to the same, and we look at the 10% GDP on healthcare. I think policymakers need to really paint a humane picture when it comes to why we really need to invest the 2% of the GDP on health research and innovation. The reason I say this is because to many policymakers, this might just sound like a statistic, but to me, it's a question of life and death. And I mean this because, as I've rightfully said, young people cannot be able to afford health. It means that, unfortunately, if they fall sick, the countries will literally lose out on the potential human resource. For this reason, the budget for research and innovation needs to be fast-tracked in the interest of saving the future human resource. Again, if you look at the number of people who are able to access healthcare workers, I'm not talking about doctors, I'm talking about healthcare workers. These are this also includes people like community health volunteers. It accounts to only two healthcare workers or healthcare volunteers per 1,000 population in Africa. In Africa, just to put things in retrospective, we are over 1.3 billion. 1.3 billion. I'm repeating this because it is best when people try to look at the statistics and to look at the need. 1.3 billion. Divide that by less than 2 doctors per 1,000. It means that it's only the creme de la creme, the very rich, that will be able to afford this. Again, if you look at the average health capacity, in Africa, it's only 6 to 81% of countries that are able to actually even afford the Africa health capacity. We hope that these numbers are changing. I don't want to paint a grim picture, but I just wanted to put it into perspective that it is very quintessential that research and innovation and technologies and studies towards this are advanced and also trickled down so that young people like myself can be involved and engaged. I will just make a simple comparative analysis of Kenya and Ethiopia. But before I do that, I just wanted to make a case on poverty-related and neglected diseases in Africa. Within the CRID coalition, I must commend organizations such as DNDi, who have done extensive work on leishmaniasis, and also IAVI, who have also done extensive work on HIV. We have also had a privilege of learning so much on technologies and methodologies that have been put in place by PATH. It would be prudent that these methodologies and technologies and medicines are fast-tracked so that they are made cheaper and available to populations that cannot afford the existing treatments and healthcare. Retrospective to also young women who are suffering, it is important to note that when young women and girls are disproportionately affected, things like gender equality cannot be realized. I do not mean to digress, but I just wanted to say when it comes to the 2 key diseases which I'm about to mention, which is HIV, AIDS, and malaria, young women and girls are mostly affected. Even if you look at the statistics by WHO, you'll most likely see maternal mortality and infant child mortality, and this normally talks about young women and girls. You'll seldom see statistics that show men that suffered from malaria, and this means that indeed investments in R&I are crucial for just making sure that gender equality is realized. In DSW, we've had the privilege of doing research and innovation for 10 years. For the last 2 years, we have attempted a pilot project in Kenya and Ethiopia, and that's why I just wanted to make a brief comparison of both. In Kenya, substantial progress has been made in reducing HIV/AIDS mortality and the infection rate. This notwithstanding, the investments towards ART treatment are still wanting. And this has deteriorated last year because most of the finances that would have been used to do such treatments were ring-fenced back to dealing with COVID at the expense of the population. Perhaps it would be crucial to kind of rethink so that we maintain services for young women and girls suffering from HIV and AIDS, because they still do need that care. They still we still need to make sure that they can access that care. Again, when you look at HIV infection and prevalence, it is widely among young people. 25 million people are still at risk of malaria, and over 5 million in Kenya are still at risk of leishmaniasis. Let me put this together. If 5 million people are at risk of leishmaniasis and malaria and HIV, it means that we are looking at potentially 5 million deaths. That's too many. And I think it would be crucial for us to now look at things retrospective of the investment so that they are fast-tracked to save lives, and not just words in as far as R&I are concerned. if we look at Ethiopia, we've seen a lot of investments, and it is commendable that the fight against malaria is still on, and the fight against HIV is still on. However, there are a lot of cases of neonatal disorders and diarrhea and tuberculosis. The reason I say this is because these diseases I'm mentioning are part of the 21 list of diseases regarded as poverty-related by WHO. And in as much as, yes, these two economies, that is Ethiopia and Kenya, can invest in R&I, it is crucial to really go a step further and say we are allotting this percentage of money towards these poverty-related and neglected diseases, because resolving one key issue, which right now is COVID, at the expense of not funding poverty-related and neglected diseases, still puts many young people at risk, and retrospective young women and girls. I keep saying young women and girls because I am in that bracket. So just to wrap up and maybe just highlight one of the things that I think is important. There have been a lot of work externally, and by externally I mean out of Africa, that have been put in place in attempt of making sure that poverty and related and neglected diseases are somewhat resolved. I say somewhat because I was just listening to John Paul, and when he mentioned about the STISA, the Science, Technology and Innovation Strategy, which is, we are only 3 years away. The Science, Technology and Innovation Strategy seeks to make sure that capacities in Africa are revamped. Medicines, diagnostic tools, and vector control tools for vaccines are promoted by 2024. That's 3 years from now. Actually, it's less than, because you're already in March. The reason why I'm bringing this up is this particular policy makes a case of why Africa needs to invest. And Africa has friends, hypothetically. I say hypothetically because it is the behavior of these friends during our time of crisis that will actually legitimize that kind of friendship. Africa has indeed improved substantially in as far as global health research and innovation is concerned. But I also wanted to highlight that the European and developing countries clinical trials partnership has done over significant work, because we've seen 700 million euros being given away to help revamp global health research and innovation projects. I believe that more funding like this can be expanded. However, I just wanted to underscore that Kenya is not yet a member of the EDCPT, and hopefully after this discussion, I will put on a motion to ensure that the Kenyan government joins the EDCPT discussion, so that we can secure funds that will be crucial for R&I. Thank you so much, Eric, for your time, and I look forward to questions and answers.
Thank you so much, Imali. There are quite a number of questions in the chat section and the Q&A section, so let's look at them and respond. At this point, I would like to quickly bring in Dr. Arono, just to give us what the figures look like within the Kenyan context. Dr. please take it over.
Thank you, Eric. I hope you can all hear me clearly.
Very well, very well.
I joined this panel with the privilege of having implemented health financing and advocacy work in a couple of African countries, and really come into the panel to bring in some hard numbers to the discussion, to really frame our conversation about how do we actualize the fiscal space for health R&D. And in the interest of time, let me just dive into a study that we have just concluded with funding from PATH, looking at what is the actual investments within health R&D in Kenya. So I will show you a few images, just a couple of slides just to anchor our conversation. I don't know if you can all see my screen.
Yes, you can see it.
So I'll just show you 3 slides on what the health research and development landscape in Kenya looks like, and this is applicable to many other countries within the continent and in other low and middle income countries. So if you look at the case of Kenya, and the previous panelists have talked about the need to invest more into health R&D. So the quick question is, how much are we investing so far? How much do we need to go? So in Kenya, there are two landmark legislation that provide for funding for health R&D. So that is the ST&I Act and the Health Act, which mandate the allocation of 2% of GDP towards the National Research Fund, and 30% of that should go towards health research. So if you look down at the actual hard numbers, those numbers should look like this. So you should have by the end of 2019 about $527 million invested into health research and development at a headline level. Those are the numbers that we need to attain. So the question is, how close are we to these targets? And I mean, what can we do to close the gap? So we looked into, so taking you back, so these are the numbers, 415 to about $427 million. Now, if you superimpose that with the actual investments, then this is how the picture looks like. So you do have, in 2017, about $50 million equivalent invested in health R&D, and that progresses all the way to 2019. And really the take-home message here is that at a high level, the funding gap relative, I mean, if you compare what Kenya has committed to versus what we put in from a government tax-oriented investment towards health R&D, we fall short by about 83%. So this is really just to bring our conversation to the actual numbers. So yes, we need to bridge the gap. How big is the gap? It's significant, and therefore we're looking at close to $400 and something million in terms of a funding gap for health R&D to at least attain the thresholds we have looked at. So why is this important? This is important because if you look at how is health R&D funded in Kenya, and we looked at a sample of studies that have been approved by the national authority in Kenya, which is NACOSTI, and you'll see that if you look at what is the distribution of funding, a majority of research that is done in the country is categorized as self-funded, and most of these are master's students or PhD students in different universities doing health R&D and funding that research themselves. About 30% of it is externally funded, with about 4% that comes from government institutions. So broadly speaking, that means that the fiscal space for health R&D, at least from a government-oriented, tax-oriented perspective, is fairly limited. And let's anchor this in reality. If you look at the fiscal space for health, it in itself is limited even before we go into health R&D. Many African countries invest about 1.7 to 2% of their GDP into health, and that really falls short of what is considered a requirement, which is in this case about 5% in the context of universal health coverage. So what is the take-home message from what I've just presented? That yes, we do have very ambitious, rigorous targets and regulation in Kenya in terms of how much should go into health R&D. I think the task is actually living up to those thresholds and ambitions and closing the gap. One way to do this is something that we have done in a couple of countries in terms of developing investment cases for different initiatives, whether it's primary healthcare or community health, and really bringing ourselves as practitioners within the health R&D to speak a language that policymakers and decision makers can understand. So we need to move away from our comfort zone and say, let's not talk about how many lives we can save with a COVID vaccine. Let's start talking about what is the economic impact of those lives, and therefore how investments in health R&D towards a vaccine or diagnostic product can compare favorably against every other investment that African governments are making, whether those are investments in infrastructure or mining or in education, so that we can go head to head and really put evidence on the table in terms of, with the limited resources, where should we be putting tax funds, and where do we anticipate the strongest return? Previously, I mean, our work in community health, for instance, has shown that for every 1 shilling you put into community health, you get about 10 shillings back, which by any standard is, you know, compares way better than many other infrastructure-oriented investments within the continent. With that, I'll pause there and hand it over back to Eric, and happy to carry this discussion forward. Thank you.
All right. Thank you so much, Daktari, for the insightful figures. And I'm happy that we have Dr. Joyce. Dr. Joyce, would you kindly take up the space? I know there's a lot of, there's a huge burden that you have to bear representing the voice of government in terms of those investments. So feel free now and take it up and share with us some of the priorities that you have for R&D for health. Thank you.
Okay, thank you, Eric, and thank you to the organizers for inviting the Ministry of Health to this conference and specifically to be part of the panelists. Thank you to my co-panelists. The ones who've gone before me have done a very good job of summarizing the situation as it is in Kenya. And I'm particularly happy that the investment bit has been done before I came on board. It makes my work easier. So we have something we call the Kenya Health Sector Strategic Plan. And from there, we call it our Bible. And that is where we get a lot of the priorities that we keep on being asked about. But specifically, I would just want to state that in the KHSSP, we do have the 6 objectives, which include communicable disease control, non-communicable disease control, issues to do with health system strengthening. And in each of those, the word research has been mentioned many times, several times. Actually, throughout the whole document, it's been mentioned more than 150 times. So yes, as government, we recognize and appreciate the role of research in all that we do. And we appreciate that at the end of the day, our greatest mandate is, as per our constitution, to ensure that every Kenyan attains the highest standards of health. So with that, then comes in, so what next? So we have what we call research priorities, and this, in terms of the actual priorities, we have even some work that we've worked with PATH and many other stakeholders in the research for health arena to come up with the priorities. And we usually revise this every 3 to 5 years. We also work with NACOSTI to really come up with the broader national health research priorities. And as you know, given that we are doing the Big 4 agenda, UHC is our primary core. So I know I've heard Dr. Arono mention UHC. UHC has been mentioned severally by the previous co-panelists. So that is where our focus is. And UHC really embraces all these issues that are coming up, including the neglected diseases, what we are having right now, emergence of diseases like COVID. At the end of the day, we want to ensure that every Kenyan can access care when they need it, at the time they need it, and really at a cost that they can bear, or if they cannot really afford, we want to ensure that we have some protection to cushion them from, from the high costs of healthcare. But for us now at the Division of Research and Innovation, when we hear the word research priorities, for us it means something else. It means what are the things that we need to be put in so that optimal research can happen in this country. And we know form follows function. So one of the things is about structures. For a long time, we've heard that research for health coordination is not the way it should be. So we have several things that we have put in place, including having a revamped research for health technical working group. Some of you are part of that technical working group. But what I really want to talk about is the National Health Research Committee, which is a body that is established under the Health Act. So when we are at the final stages of gazetting this committee, and when this committee comes on board, a lot of these issues that we've been talking a lot about will be systematically handled, or rather that is our prayer. So things like advocacy for increased funding, for example, things like access to a national research database, issues to do with coordination of the research for health generally in the country. One of the things that we have found out is there's quite some duplication when it comes to even the research that is conducted in this country. So we can't wait to have the NHRC on board. The other thing would be we really want to, or rather we are really working to ensure that the researches that are done in the country are for action. One of my previous co-panelists mentioned that, I think it was you, John Paul, that a lot of the researches that are done, or not, let me not use the word a lot, we have quite a number of researches done, but the end game usually is, can we publish? So one of the things at the Ministry of Health is that the DG, or the Director General of Health, is really interested in the results of researches that are being done in the country. And we are setting up a knowledge management hub at the ministry and working with partners, working with our clients, we like to call our stakeholders, to ensure that we reduce the no-do gap. So how do we do this? We are looking at things like capacity building. We are looking at issues of even having rapid response centers in the counties. So it's work in progress, but we are hoping that at the end of the day, research will not just be done so that people can publish in JAIDS, for example, but really that we turn that into policy, and that policy is used, even if it's not at the macro level, at the national level, it is used at the level where the research was done. So that's the other thing that we are working with. So we have issues to do with setting up of knowledge translation platforms and repositories. So we have the Kenya Health and Research Observatory, which is the phase 2 has just been completed. Actually, this morning we had a meeting with the Ethical Review Committee focal persons so that we can ensure that the work that they do to review and approve research protocols, we are able to have that in one place, and then we now proceed through the whole research cycle of eventually ensuring that once the researchers complete the studies, that we get those results and translate. We understand in countries like Rwanda, translation into things like policy briefs takes about 3 months. I understand in Kenya, it's been taking about 3 years. So we need to do something. At the Ministry of Health, the mid-level management where I am, we thank God for COVID. Why do I say so? Because it is through COVID that our top management realized the capacity that the ministry has regarding things like even evidence reviews, rapid evidence reviews, but more so realize the importance of investing in research. Last year in May, let me just finish. Last year in May, our president, His Excellency, President Uhuru, during one of the COVID updates, really talked about enhancing research in this country. And he said several statements in his speech towards that end. And as a result, we were able to do a technical brief that really talked about what does it mean to enhance research in this country. Research is more than funding. Research is about even ensuring that infrastructurally we are on top of things. We need supra labs in this country. We don't have to always be sending our samples to other countries. I'm always encouraged by countries like South Africa who have a lot of that. I mean, the things that we look forward to having in this country. So it's beyond funding. So funding is one thing, but we need infrastructure. we have a lot of capacity, but we are underutilizing it. And then issues to do with even data management and use of big data. So there are several things we wrote in that technical brief so that it could be then pushed to the Office of the Presidency. And we are hoping it's through such things that we get to advocate for, funding and also anything that we need to ensure that optimal research for health takes place.
Okay. All right.
Yeah.
Thank you. Thank you.
Eric.
Thank you so much, Dr. Sorry, we have run out of time. We still have Catherine and Lorraine. Catherine, maybe just in closing, what would you just help us sum up all this into some kind of an end goal, as we seek to advance R&D agenda? Dr. Catherine?
So thanks everyone, and I hope I'll be able to do it as fast as possible. So when I know that I don't have time, I speak very fast, and I hope you all keep up. So I think I'll start from John Paul's presentation about resilience. And my own definition is that the ability to function and thrive regardless of the scope and depth or the scope and scale of shocks and stresses. So I think that's one thing to start. And I think one of the things he said that a resilient system is prepared with tools to respond to the shock, but also has systems that sort of can be mobilized or repurposed, to produce new tools and more, systems that can now, help the system to function and thrive and for people to thrive. So looking at that, what does that mean? And one of the things he mentioned is capacity. And I wanted to sort of take a slightly different take and say that I think the future of African R&D is in regional collaboration and cooperation, and not necessarily in individual countries trying to set up a sufficient R&D capacity. And I'll say why. When you think about capacity, there are already some ongoing initiatives that are actually led by the AU. And I can't go into all the details, but I'll post the links for this. There's an African Higher Education Centers of Excellence initiative that is going on, where there's a recognition that for the kinds of R&D needs that Africa has, it's not possible to have every single university offering these kinds of things. So they've sort of consolidated training programs, research programs in priority areas, so that there's one set of excellence that the whole continent can use for training in research, but also for starting research programs. There's another one called the Pan-African University, and it's the same sort of thinking that you can't have every university or every country setting up its own, let's say, university in space sciences. So there are already initiatives where the AU has recognized that pooling resources can actually generate the R&D capacity that Africa needs. And then the last one is the Alliance for Accelerating Excellence in Science in Africa, which is the AISA platform, which is hosted by the African Academy of Sciences. And it's the same principle. And this was, it's a partnership between the AU Development Agency, but also other partners that are mostly funding agencies that are pooling money to shift the center of gravity of research on Africa or science on Africa in Africa. So lots of initiatives that is churning out, training programs, research grants, and all that. So I think that's maybe the shift that we need to think about, that when you think about the cost of R&D, it may be difficult for a single country to set up sufficient R&D infrastructure and sustain it and fund it in a way that is going to produce the solution that Africa needs. And I'll just give a very quick example. I was reading up how long it takes, how much money it takes to develop a vaccine. So if you look at a single vaccine candidate up to phase 2A, which is after the first safety trials, it costs between $30 and $70 million, one vaccine candidate. However, there's a huge cost of failure. If you start with 15 candidates, you end up with one. So who's going to fund the failure of vaccine development? So when you look at the cost of failure, it stops being $30 to $70 million and goes up to $320 to $470 million for the success through phase 2A. By the time the vaccine is registered, the costs go up to about $2.5 billion. One vaccine. So think about one vaccine, think about diagnostics, think about malaria treatments, new TB treatments, and all that. So I don't think it's realistic for us to expect that one single country can put up $2.5 billion expecting to get one single vaccine being successful for all the problems that we have as a continent. Now, having said that, the question is the so what? So the so what, I think, is who is the target for this so what? So for the African leadership, if they are listening, I would say, let's focus on consolidating our resources. Just imagine if every single country was putting up just a single $1 million. That's about $50 million available for setting up this infrastructure every year that can now be the engine for driving R&D in Africa. So let's focus on a regional approach. The foundation exists. What's going to happen at the Pan-African University? What's going to happen at the African Centers of Excellence? Can we build on that? Those foundations already exist. There's infrastructure, there are people who have been trained, there are people who have expertise, so let's build on that. The third is commitments. There are so many commitments. Maybe stop making new ones and let's focus on the ones which are there, because there are commitments for health and R&D. I mean, health expenditure, R&D. You know, what proportion of GDP and all that. Let's stop. Let's focus on those which are there. Now, the second audience is us, because we are the victims of inaction, more or less. If our governments don't do, we are the ones who are saying, okay, when will the vaccine come? You know, when will this happen? So what can we do? And one of the things that I said I think is important is we need to make the case better, because these analyses are there, the benefits of R&D, you know, the return on investment, they're there, but perhaps we need to make a different case, because this case doesn't seem to be sticking, you know, with our you know, policymakers. But the bigger question is, who should be the messenger? And when you think about R&D, most governments see the public universities where they're already putting money to support, you know, training and all that. So our messengers perhaps should stop being us who are outside the system, and they should be those people who are the direct beneficiaries of government, and who are perhaps the people government sees as partners in R&D. And so the question is, what case should they be making? Is it possible to have a continent-wide message that is consistent? Is it possible to have a regional approach so that Makerere University, when they sit with Museveni, they're not saying give Makerere University more money. Maybe they're making a case for a regional pot of money. The messengers equipped to make the same case that Jose can make, or the same case that John Paul can make. So as the victims of inaction, perhaps we should shift, you know, find the allies, find the partners, equip them, you know, and let's try to get consensus about a consistent message about R&D. Right. And last, let's develop new models. It's one thing to tell government that you need to do this, but if you can show this is what was done by the EU, or this is what was done by South Africa, then it's much easier rather than invest more in R&D. So I'll stop there in the interest of time.
Thank you.
And hope to answer any questions that may come. Thanks.
Thank you, Doc. There are questions on the Q&A. Feel free to go in and respond. I know we have to bring this to a close, and thanks to the team for giving us just additional minutes. Laureen, unfortunately, you're coming in at the tail end. Any final quick thoughts in a minute, or maybe some experience you can share within that short time? Laureen.
Good afternoon, everyone, and thank you. I think for me, as a South African, we've waded into a universal healthcare in the form of national health insurance, and we are currently busy with that. I think, though, at a heart, I'm a patient, and I think that's where my outlook comes from. And I think if we can be left with one thing today, is that what does innovation mean for patients and communities and citizens? Well, it means nothing if those citizens and communities can't get access to it. And for me, I think that speaks to where we're looking at some of the research that we've looked at, and how do we include the innovation and the drawings of research and R&D in health into that principle, that if we can't get access, then the innovation is not worth anything. In South Africa, we're walking slowly towards trying to include R&D and health into our universal health care and health coverage through the National Health Insurance. We've looked at the National Health Insurance Act, which is currently sitting before Parliament, which includes quite a bit of health R&D, even though it doesn't look like it initially. So it looks like, initially you would look at it and say, well, there's no clear budget for health R&D in this, but it has developed in that bill the need for a health technology assessment agency within the National Health Insurance. It's also taking in the work and the subsidies that we are currently spreading and putting it into one health system. Because at the moment, we're currently spreading it across 2 health systems. So any R&D we're doing, it has a place in the public health system and it has a place in the private health system. So that's an immediate savings on that. I think ultimately, when we look at it from a universal health coverage, I would request that researchers and researchers as health R&D researchers particularly look at the principles of universal health coverage, where it looks at how do we financially protect people from risk, how do we improve their access to services, and how do we improve their health outcomes. So I think I'm going to leave it there. Everyone's had a lot to talk about today, but just to know that I know that South Africa was mentioned quite a few times today, and we haven't got it completely right. We're working towards it, and with advocates, R&D advocates such as myself and the colleagues at SATAG, we're slowly getting it to be a political and a policy on the political and policy agenda. One thing, a piece of advice I would give you is that perhaps in your policies, something that could be considered and used for R&D might not look to the naked eye when you first look at those policies and laws and that as R&D. And I would look at us as the R&D fraternity, particularly in Africa, to say, where are those opportunities where we can leverage what already exists to make it better for health R&D? Thank you.
Well said, Lauren. Well said, where the opportunities are, and I'm happy the team is here. Let's keep putting our efforts together. Let's keep linking up. I know this is just one of the platforms, but allow me to appreciate all the team members, all the panelists who've been here with us. We have the participants who've also